Welcome to Connections, a new initiative of the Israel Journal of Health Policy Research. Connections uses Zoom to host focused conversations between scholars and policymakers from Israel and abroad. In these conversations, we explore the international and policy significance of selected articles published in Israel's leading health policy journal. My name is Bruce Rosen, and I'm the co-editor of that journal. I'm also the director of the Smoker Center for Health Policy Research at the Myers-JDC-Brookdale Institute. In today's session of Connections, we're going to be talking about the growing role of telemedicine in pediatric care, the care of children. We will explore the potential of telemedicine, its limits, and how it needs to be organized. Joining me in today's session of Connections, I have two distinguished guests, both of whom are experienced primary care pediatricians and respected thought leaders. Dr. Tzach Grossman is a professor at the Medical School of Ariel University. He is also the president of the Israel Pediatric Association and the scientific director of the European Network for Pediatric Research in Ambulatory Settings. Dr. Gary Fried is a professor at the University of Michigan and one of the world's leading pediatric health services researchers. He is a past president of the Society for Pediatric Research, the largest research society in the field of child health. He is also deeply familiar with Israeli healthcare and serves as the chair of Brookdale's International Health Advisory Team. About a year ago, Dr. Grossman published in our journal an article entitled "The Future of Telemedicine Visits After COVID-19, Perceptions of Primary Care Pediatricians." That article has generated a lot of interest and has already been downloaded over 5,000 times and cited in 12 other academic articles. I'd like to begin by asking you, Tzachi, to give us a quick summary of the main points of that article, and then to update us on how the situation in Israel has evolved over the past year.
Okay, so there are three main points that I would like to highlight from the paper that we've published. First, we asked pediatricians about their attitudes towards telemedicine technologies and decision-making via telemedicine. In May 2020, we did a survey, and we asked them about the use of the technologies before the COVID-19, during the pandemic, and what is their prediction of the future use of these technologies. We asked them about the decision-making of various scenarios in which they were asked about their predilection to write antibiotic prescription via telemedicine. And we've also examined the actual visit composition in person and phone visits. We have explored it at that period. So what we found was that the pediatrician, as expected, their use of various technologies made a big rise during the COVID-19 as compared to before the COVID-19, but the predicted use after the pandemic is over was again lower. So they thought they will not use these technologies as in COVID-19. The second thing is that their tendency to write antibiotic prescriptions only by telemedicine, description of the parents, for example, otitis cases or pneumonia cases. Again, in the pandemic, they showed a big tendency to do it, but they predicted that after the pandemic is over, they will revert again to prefer physical examination in office in order to treat these cases. And the third thing is that when we explored the composition of visits, we did see at the beginning of the lockdown, the first lockdown, that there was a sharp rise in phone visits and a sharp decrease in frontal visits, of in-person visits. But as we went on and the lockdown was lifted and life came back to some kind of normal, which is actually what is happening even now, we came to saw a hybrid use of technologies, meaning that the phone visits and the in-person visits coexist together in some kind of hybrid medicine. These are the three main points that were found in our paper.
And how have things changed since you published the paper?
Since we published the paper, the hybrid composition stays with us, meaning that mostly people come for frontal visits, for in-person visits, but there is a fixed percentage of visits which are phone visits. So, and this was not existent at all before COVID-19, of course. So it appears that the hybridization of visits is what is now happening, and it goes on since last year until today. We have a rise of corona cases, a decreased number of cases, but this fashion of hybridization is persisting.
Exactly, that's a great start for us. I'll now turn to Gary for a U.S. perspective. Gary, how is this phenomenon playing out in the U.S.? In what ways is it similar to and different from the Israeli situation?
Thanks, Bruce, and thanks, Dr. Grossman. I think in some ways it's actually quite similar. As Dr. Grossman pointed out, there was an initial increase in what we call virtual visits during the time of the increased number of cases in COVID and the lockdown. And rather than phone, many providers in the United States really tried to do visits much more so by video and through the different video mechanisms. Now that created a problem for a small subset of families because they either A, lacked the technology, or B, lacked a reliable internet connection. And so that's something that we became aware of, is that there may be an economic gradient relative to the availability of virtual visits. The other thing that I think is really key, as Dr. Grossman pointed out, is that initially parents made this decision to pursue virtual visits for a couple of different reasons. Number one, many practices closed down, and they certainly just didn't have the option of in-person visits. The other thing was, for when parents did have the option, there was concern among parents to not want to go to healthcare centers or to providers because of the risk of exposure of either them or their children to potentially other people with COVID, because there was so much uncertainty about how this all played out. There certainly were benefits to using the technology, and for parents, when there's been a couple of studies here that have looked at how parents feel about virtual visits, and the convenience factor is certainly the highest one on the list, that you can, literally just stick your kid in front of the camera as opposed to having to bring them in, and that makes it a lot easier.
Almost like taking them to school. You just stick them in front of the camera and that's it.
Yeah, I think in many respects there was there's a parallel there, and parents were fine with that for minor illnesses. It worked best, it turns out, for mental health visits that didn't require physical examination and follow-up of mental health concerns. The concerns that parents had, though, were whether or not things would be missed because their child wasn't having a physical exam, and that they were okay with this for what they considered minor illnesses, but anything that was more substantive, they really wanted an in-person visit, which, makes sense to me. There was also the experience of some parents who would try the virtual visits, but then would end up having that being converted to an in-person visit anyway. And that's just, I think, the nature of the beast and how this turns out. Now, from the provider side, there were a lot of different issues that surrounded this. And one of the big ones was, how would providers get paid in terms of the way in which virtual visits were reimbursed? Because we, for the most part, even though we have many people in managed care plans, we operate on a fee-for-service mechanism. So how would virtual visits be paid, if they would be paid, relative to in-person visits? And right now, we're still in a transition phase where many insurance companies and the federal government here pay for virtual visits, at almost, but not quite the same rate as in-person visits. How long that'll last, no one really knows, or what the ultimate financial aspect of this will be, but that'll be a real factor for providers, especially in primary care where the margins are smaller, to make the decision of how they're going to, play this out. The other issue for providers was a concern about liability, because it would be easier to miss things over video or over, a camera than it would if they were actually laying hands on a child. So I think those would be some of the bigger concerns. One other advantage that people hypothesize, but we're not really sure, is that we might have fewer no-shows for appointments, that we might have, people show up at a higher rate, especially in hard to reach populations. So it's a kind of a double-edged sword about the technology concern versus would this make it easier for people with hectic and chaotic lives to be able to actually have visits? And no one's really sure how that'll play out. The last thing I want to say is, like what Dr. Grossman said, is that it's unclear how this will all play out in the long run, obviously, because since we were able to return to in-person visits, there's been a lot of in-person visits, and especially for what we call health maintenance exams or checkups, where kids would get vaccines. We can't do that by telemedicine. We can't do that, by video. So we really need to be able to have people in person for some of those regular preventive visits that we provide.
Thanks, Gary. Before we move on, Tzachi, do you want to relate any of the points that Gary raised?
Yes, I was going to talk on it a little bit later, but Dr. Fried has raised the issue of payment, which is a striking difference between what's happening in the US and here, because in Israel, everyone is insured, and there are 4 health funds supplying the service, and it's actually a capitated, either a passive capitation or active capitation form of services, which means actually that virtual visits are in the package of services as in-person visits, meaning that physicians are getting paid according to the number of people they registered in their practice, or they saw them in the quarter, but of a year. But it doesn't really matter if they saw them in person or virtually; they get the same payment. This is a very striking difference.
Okay, Tzachi, Gary mentioned that in the U.S., as opposed to phone, there's a lot of video meetings. Is that happening in Israel as well?
It is developing. In some of the health funds, it is more developed than in others, but still the main channel of virtual telemedicine now is still by the phone, and but the video channel is developing. And one more thing, which is developing in the Israel, and I don't know if it's at all in the US, is the peripheral devices. For example, like a digital otoscope. There is a company here named Taito, which is distributing these otoscopes to families, and it gives another dimension to the telemedicine visits. And I'm sure that here the use of Taito will increase. I don't know about other digital peripheral devices, but the digital otoscope here is gaining much popularity.
I think that's a really interesting point. I'm not aware of it. I mean, it could be happening, obviously, but it's certainly not prevalent here, those types of technologies. I mean, we use them in different ways, like people do blood pressure, right? And those things are sent in electronically, or, glucose levels for diabetes are recorded electronically and sent in. I think that's going to be an area of real interest going forward, like Dr. Grossman said, about whether or not how we can incorporate physical exam components into that.
Yeah.
It's really, we're not there yet by far. And one thing that I was thinking about while Dr. Grossman was talking, and that we rushed into video visits here as opposed to telephone visits, and the technology for privacy had to catch up with that. Like, we were all familiar with Zoom bombing and all those kind of things. And so we were doing video visits without really having a secure connection with many of our patients. And in terms of mental health and other types of issues, that became obvious. So the Zoom, and I'm sure other other platforms as well, have engineered secure environments so that if I was to do a video visit with a patient, I have a special Zoom portal that I have to go through that is secure. And then the other question is, are these going to be recorded? We have the ability to record these video encounters, and there's a whole issue both of privacy with that, as well as if it turns out to become, let's say, a standard of care for liability purposes or whatever it might be, that's going to be a huge storage issue. And I don't know who's going to pay for that, or, how big the cloud is to handle this stuff.
I think that what you've mentioned now has happened in the beginning of the pandemic. Both these issues of privacy and the optimal medical record, these things happened early in the pandemic, that people sent pictures and clips to the physician's smartphone. Because the formal channels were not existent a year ago. Now they are, but at the beginning of the COVID-19, these channels were not developed at all. So people just sent a picture of a rash to the physician, which is of course not adequate, both in terms of privacy and in terms of keeping a suitable medical record.
So thank you for bringing that up, Dr. Grossman. Prior to COVID, many of our EMRs in America have patient portals where patients can communicate via the medical record with their providers. And it's honestly the bane of the existence of most providers is dealing with the patient portal, because of the volume of things that come through there that honestly many times are either not reimbursed, or there's no mechanism to account for the time it takes to do that. So people were sending us pictures of rashes.
And birthday parties also, probably.
Fortunately, I never got those.
Okay.
But over the last couple of years, probably the last 2 or 3 years, parents have started to have an expectation that they could send a picture of a rash and get some kind of response. Now, the good news is those become part of the medical record. The more difficult thing is that I think it's created an unrealistic expectation on the part of parents with regard to both the availability of professional time to deal with that, as well as an unrealistic expectation of the quality of their photography.
Tzachary, you've seen the same issue in Israel?
Yes, but it was not to such an extent that really bothered the physicians. I think that in the beginning they even liked to get these pictures, and we also saw it in our paper that one of the channels that both physicians would like to keep ongoing after COVID-19 is the issue of pictures. We clearly saw it that this was something that was discovered during COVID-19, because before, I think parents did not send rashes to the physicians, but COVID-19 has shown that sending a picture of rashes is really a very efficient way to deal with dermatologic issues.
Okay, Gary, going to move on.
I think that Dr. Grossman brings up a really great contrast between what the impact of payment has on whether or not people want to get a lot of messages through their portal. Because in a capitated system, the most efficient way that you can take care of people is going to be the best way you can do it. In our system, we would be giving out a lot of free care, basically, for a lot of because we're paid on a fee-for-service basis. So I think the different systems set up different incentives for how to deal with things. And I'm not saying one's right and one's wrong. I'm just saying that, the system is different, and how providers look at these different technologies may differ, not just in Israel and the US, but certainly in other countries, based on their payment systems.
Yeah.
So you guys have both highlighted a number of challenges and things that need to get put straight. what roles do you see for government, medical associations, medical schools, providers, and others? What's their responsibilities of those different groups in organizing this new phenomenon?
Well, I think that there are two major roles. One role is writing the standards for things that we have already discussed here, the privacy, the medical record, the various technologies that are suitable for transfer of information, risk management issues. All these standardizations should be done by professional associations and, of course, the government also. So making standards is the first priority. The second priority is training of personnel. I think that being a good physician, a good pediatrician in office does not mean that you're also a good pediatrician for virtual visits, either by phone, by video, whatever. People should be trained how to do it with all the aspects that I've been talking about, the risk management, what is appropriate and what is not, the minimal age for telemedicine, etc. All these issues should be out of the training. And also, I think that education of parents, what to expect from the virtual visits. This is also part of what should be done. Sometimes parents do not have the adequate expectations in all terms of the visit. And so training of providers and education of consumers, parents in our case, is again a very big mission of the associations mainly, in addition to the standards that I've already talked about.
Gary, anything to add on that?
I agree 100% with what Dr. Grossman said, especially about creating expectations on both directions, on the part of parents and on the part of providers. And I can say in my experience, and I would hypothesize this is relatively true in most of the United States, we just threw our trainees into giving these virtual visits, just like we were thrown into as providers, and that we haven't done the due diligence yet to develop the types of curricular elements that Dr. Grossman mentioned about what should be a part of a good video visit, what are the things you really need to look out for, what are the limitations. And I think that that's an area that we really, really need to concentrate on. With regard to government setting standards, I believe this is one area where this will be much more complex in the United States than in Israel. Not because I think that's a good thing, it's because much of our liability issues and regulatory issues are at the state level. They're not at the federal level because of, for those who may be listening who aren't aware, the 10th Amendment to the US Constitution says that all powers not specifically granted to the federal government are left to the states, which is why, because healthcare isn't mentioned in the Constitution, which is why you have to have a license to practice medicine by your state. There is no federal license to practice medicine. So when I moved to my current state of Michigan, I had to get a license in Michigan, even though I had been licensed in North Carolina before I came here. So that also means that liability laws vary from state to state. So it will be something that I think the federal government can provide some guidance on, and certainly can use some of its regulatory power, but every one of these states is going to have to deal with this. And we have, quite as many of you who just watch the news know, there's a lot of difference between many of our states in terms of their sophistication in not only healthcare, but also in regulatory efforts. So I think the fact that Israel can do this at a national level is going to be a real benefit for how this can be rolled out uniformly, and that both providers and parents or patients will be able to deal with it in an easier way.
Okay, now for my last question. I'd like to turn to the issue of research. What do each of you see as the ways in which research can best help our two countries effectively develop the telemedicine for children?
I would like to mention two research directions. One is going back to the peripheral devices. We will try to study how to integrate digital otoscope and digital devices into the telemedicine service. This is one channel. And the other channel is a very interesting one. We have only recently started talking about home hospitalizations of children in situations where they do not need the hospital. For example, children who should get a few days of IV treatment, instead of lying in the pediatric department, they can lie at home, and the monitoring of their status can be hypothetically done via telemedicine. So this is another channel which is only now starting, but if home hospitalization will be for children will be regulatory approved, then we should try to see how to integrate telemedicine care of these children at home.
Good. Gary?
I think those are really great points. I agree. The other two things I would say in research is we need to figure out which types of visits these telemedicine visits work for best and which ones they don't. And right now, we really don't have enough experience to know what we're missing, what we're not missing, and how these should play out, both in terms of the clinical significance, but also the patient experience with them, and whether or not, if there's ways that these can be tailored to improve, because basically we've all just been winging it, as time goes on. The other thing is, I mentioned before, whether or not these visits can be recorded. We might be able to, through recording of these visits, also learn more about the patient experience and their interactions with providers. Right now in the US, we are thinking a lot about equity and whether or not we treat people the same, and whether that's because of race or ethnicity, or because of income gradient, or because of ability or disability status, or sexual orientation. And a lot of times, in experimental designs, people video visits, to see if people do things differently. We may have the opportunity now to be able to do that, since they're going to be on video anyway, in a much more robust fashion that could, in fact, allow both patients and providers to be blinded to the idea that this would occur, so that they wouldn't necessarily be performative when they're carrying out these evaluations. So I think that there may be an equity angle for research for us to learn. Are we talking to people differently? Are we treating them differently? Are we spending less time or more time with certain types of patients? Those are concerns we have now, but don't have the answers to. And this technology may be able to help us do that.
Terrific. Thank you so much for your responses to that question. And thank you for joining me here on IJHPR Connections. We look forward to sharing this conversation with policymakers, scholars, and the general public in Israel, the US, and beyond. We also look forward to continuing this conversation with the two of you, Tzachi and Gary, either through the Israel Journal of Health Policy Research or through other vehicles. So thank you very much.
Thank you, Bruce. Thank you, Gary.
Thank y'all both. It was great. Oh, it was great.